Principles of Pediatric Pharmacotherapy. The principles of pediatric pharmacotherapy emphasize that the medication use process in children is inherently complex and prone to errors. This complexity arises from the unique physiological characteristics of pediatric patients, which require careful consideration when selecting and administering medications. Despite these challenges, remarkable progress has been made in the clinical management of diseases affecting pediatric patients. Over time, advancements in medical knowledge, improved preventive measures, and better therapeutic interventions have significantly enhanced child health outcomes. One of the most notable indicators of this progress is the dramatic decline in infant mortality. Rates have decreased from approximately 200 deaths per 1,000 births in the 19th century to 75 per 1,000 births in 1925, and further down to 6.79 per 1,000 births by 2004, reflecting substantial improvements in pediatric healthcare. This success has largely resulted from improvements in the identification, prevention, and treatment of diseases that were once common during delivery and early infancy. In the past, a lack of adequate knowledge and clinical data led to serious medical disasters. Notable examples include gray baby syndrome associated with chloramphenicol, phocomelia caused by thalidomide, and kernicterus resulting from sulfonamide therapy. These events highlighted the critical need for evidence-based approaches in pediatric care. Another major concern in pediatric pharmacotherapy is determining the optimal drug dosage. Dosage regimens cannot be based solely on body weight or body surface area by simply extrapolating from adult data. Key parameters such as bioavailability, BA, pharmacokinetics, PK, pharmacodynamics, PD, efficacy, and the risk of adverse effects can differ significantly between pediatric and adult patients. Furthermore, these factors may also vary widely among pediatric patients themselves due to differences in age, organ maturity, and underlying disease conditions. Significant progress has been made in the field of pediatric pharmacokinetics over the past 2 decades. However, relatively few studies have successfully linked pharmacokinetic data with important clinical outcomes such as efficacy, adverse effects, and quality of life. This gap highlights the need for more comprehensive research that connects drug behavior in the body with real-world therapeutic results in pediatric patients. In addition to pharmacokinetic considerations, several other factors must be taken into account when optimizing drug therapy in children. These include the availability of suitable dosage forms tailored to pediatric needs, the safe and effective delivery of intravenous medications to infants and children, and the ethical justification for conducting research in this vulnerable population. Together, these considerations are essential for ensuring safe, effective, and evidence-based pediatric pharmacotherapy. Enormous progress has been made in the study of pharmacokinetics, PK, in pediatric patients. 2 key factors have contributed significantly to this advancement. First, the availability of highly sensitive and specific analytical methods has made it possible to measure drugs and their metabolites accurately using very small volumes of biological fluids, which is especially important in infants and children. Second, there has been increased awareness of the critical role that clinical pharmacokinetics plays in optimizing drug therapy and improving therapeutic outcomes in pediatric populations. Despite these advances, it is important to recognize that the absorption, distribution, metabolism, and excretion (ADME) of many drugs differ substantially among premature infants, full-term infants, and older children. These differences are primarily due to variations in physiological development and organ function across different stages of growth, necessitating careful consideration when selecting and dosing medications in pediatric patients. Absorption. Drug absorption from the gastrointestinal tract, GIT, in pediatric patients is primarily influenced by 2 key factors: pH-dependent passive diffusion and gastric emptying time, GET. These processes play a critical role in determining how effectively medications are absorbed after oral administration. Both pH and gastric emptying differ significantly in premature infants compared with older children and adults. In full-term infants, gastric pH is relatively high at birth, typically ranging from 6 to 8, but it rapidly decreases to between 1 and 3 within the first 24 hours of life. In contrast, premature infants tend to have persistently elevated gastric pH levels due to immature acid secretion. These developmental differences can significantly affect drug solubility, stability, and overall absorption in the gastrointestinal tract. A few studies involving drugs such as digoxin and phenobarbital, as well as nutrients like arabinose and xylose, suggest that both passive and active transport mechanisms in the gastrointestinal tract may be fully developed by approximately 4 months of age. This indicates that drug absorption processes mature significantly during early infancy. However, there is still limited knowledge regarding the development and expression of certain transport systems, such as the efflux transporter P-glycoprotein and intestinal drug metabolizing enzymes. The extent to which these factors influence drug absorption and bioavailability in infants and children remains unclear and requires further investigation. Additionally, studies have demonstrated that gastric emptying is slower in premature infants. This delayed gastric emptying can further influence the rate and extent of drug absorption, contributing to variability in therapeutic response in this population. Drug absorption from intramuscular (IM) sites can be significantly altered in premature infants compared with older children and adults. Several physiological factors contribute to this variability, including lower relative muscle mass, poor perfusion to certain muscles, peripheral vasomotor instability, and insufficient muscular contractions. The combined effect of these factors on drug absorption is difficult to predict. For example, phenobarbital has been reported to be absorbed rapidly after IM administration, whereas diazepam absorption may be delayed. Because of this unpredictability, intramuscular dosing is rarely used in neonates, except in emergency situations or when an intravenous route is not accessible. Percutaneous drug absorption can be substantially increased in newborns due to an underdeveloped epidermal barrier, particularly the stratum corneum, and higher skin hydration. In addition, the ratio of total body surface area to total body weight, TBW, is highest in the youngest infants. As a result, the relative systemic exposure to topically applied drugs, including corticosteroids, may be significantly greater in infants and young children than in adults. This increased systemic exposure can lead to toxic effects. Notable examples include adverse reactions from the use of hexachlorophene soaps and powders, salicylic acid ointment, and rubbing alcohol. Interestingly, studies have also shown that therapeutic serum concentrations of certain medications, such as theophylline, can be achieved through topical application. In premature infants under 30 weeks gestation, a standard dose of theophylline gel has been effective for controlling apnea, demonstrating both the potential and the risks of enhanced percutaneous absorption in this population. A transdermal patch formulation of methylphenidate has been approved for use in children aged 6 to 12 years for the treatment of attention deficit/hyperactivity disorder, ADHD. The patch is designed for once-daily application and can remain in place during normal daily activities, including bathing, swimming, and exercising, providing convenient and consistent drug delivery. Distribution. Drug distribution in the body is influenced by both the physicochemical properties of the drug, such as its pK, molecular weight, and partition coefficient, and patient-specific physiological factors. While the drug's physicochemical characteristics remain constant, physiological functions, including blood flow, body composition, and protein binding, can vary widely across different patient populations, affecting how the drug is distributed and ultimately its therapeutic effect. Several patient-specific factors play a crucial role in drug distribution, including extracellular and total body water, plasma protein binding, and the presence of pathological conditions that may alter normal physiological function. Total body water, expressed as a percentage of total body weight, varies significantly with age. Approximately 94% in fetuses, 85% in premature infants, 78% in full-term infants, and 60% in adults. These differences have important implications for the distribution of hydrophilic drugs in pediatric populations. Extracellular fluid, ECF, volume also differs markedly between premature infants, older children, and adults. In premature infants, the ECF may account for up to 50% of body weight, compared with 35% in 4 to 6-month-old infants, 25% in 1-year-old children, and 19% in adults. These variations are reflected in the pharmacokinetics of certain drugs. For example, The distribution volume of gentamicin is 0.48 L/kg in neonates compared with 0.20 L/kg in adults, demonstrating how age-related differences in body composition can affect drug distribution. Breastfeeding considerations are critical in pediatric pharmacotherapy. The American Academy of Pediatrics recommends that certain drugs, including bromocriptine, cyclophosphamide, cyclosporin, doxorubicin, ergotamine, lithium, methotrexate, phenedione, and all drugs of abuse such as amphetamine, cocaine, heroin, marijuana, and phencyclidine, PCP, should not be used during breastfeeding. Additionally, the use of nuclear medicines should be temporarily discontinued while nursing to prevent potential harm to the infant. Metabolism. Drug metabolism in infants is substantially slower than in older children and adults. While the sulfation pathway is generally well developed, the glucuronidation pathway is immature in infants. For example, acetaminophen metabolism via glucuronidation is impaired in infants, but is partially compensated by the sulfation pathway. This immaturity in metabolic pathways is also responsible for serious adverse events, such as the chloramphenicol-induced gray baby syndrome, which occurs due to decreased metabolism of chloramphenicol by glucuronyl transferases, preventing its conversion to the inactive glucuronide metabolite. Higher serum concentrations of morphine are often required to achieve therapeutic efficacy in premature infants compared with adults. This is partly because infants have an immature capacity to metabolize morphine into its 6-glucuronide metabolite, which is approximately 20 times more potent than morphine itself. Additionally, morphine clearance increases significantly with age, quadrupling between 27 and 40 weeks of post-conceptional age. Other drugs metabolized by oxidative pathways, such as theophylline, phenobarbital, and phenytoin, also show impaired metabolism in newborn infants, reflecting the immaturity of hepatic enzyme systems. The clearance of theophylline is similarly underdeveloped for several months after birth. Two important observations about theophylline metabolism via CYP1A2 have been noted. First, in premature infants treated with theophylline for apnea, a significant portion of the active metabolite caffeine may be present, a pattern not typically seen in older children or adults. Second, theophylline clearance in children aged 1 to 9 years exceeds that observed in both infants and adults. As a result, children with conditions such as asthma often require substantially higher weight-based doses of theophylline compared with adults to achieve therapeutic effects. Because of their reduced metabolic capacity, doses of drugs such as theophylline, phenobarbital, phenytoin, and diazepam should be decreased in premature infants to prevent toxicity. Elimination. Drug clearance can vary significantly with age and developmental stage. For example, the clearance of unbound S-warfarin, a substrate of CYP2C9, is substantially higher in prepubertal children compared with pubertal children and adults, even after adjusting for total body weight. Similarly, the clearance of caffeine, which is metabolized primarily by demethylation, gradually declines to adult values as children mature. This occurs when girls reach Tanner stage 2, early puberty, and boys reach Tanner stages 4 and V, late puberty. Advances in pharmacogenetics and pharmacogenomics are increasingly being applied in clinical practice to tailor drug therapy based on individual genetic and developmental factors, helping optimize efficacy and minimize adverse effects. Drug efficacy and toxicity. Insulin requirements are highest during adolescence due to the rapid growth and increased metabolic demands of this period. Certain medications, however, carry age-specific risks in pediatric patients. For example, promethazine is now contraindicated in children younger than 2 years because of the potential for severe respiratory depression. Similarly, chloramphenicol toxicity is increased in newborns as a result of immature metabolism and enhanced bioavailability. Other substances commonly used in drug formulations can also pose risks to infants. Propylene glycol, often added to injectable medications such as phenytoin, phenobarbital, digoxin, diazepam, vitamin D, and hydralazine to improve stability, may cause hyperosmolality in this population. Benzyl alcohol, previously used as a preservative in intravascular flush solutions, was associated with a severe syndrome in premature, low birth weight infants. This syndrome included metabolic acidosis, seizures, neurologic deterioration, gasping respirations, hepatic and renal abnormalities, cardiovascular collapse, and even death. Following the discontinuation of benzyl alcohol in these solutions, both mortality and the incidence of major intraventricular hemorrhage in low birth weight infants declined significantly, highlighting the importance of careful consideration of excipients in pediatric medications. Tetracycline class antibiotics have long been taught in pediatric and pharmacotherapy texts to be contraindicated in pregnant women, nursing mothers, and children younger than 8 years because they chelate calcium and can become incorporated into developing teeth and bone, leading to permanent tooth discoloration, typically yellow, brown, or gray, and defects in enamelization of both deciduous and permanent teeth, as well as inhibition of long bone growth when exposure occurs during critical periods of mineralization. These effects are mediated by the drug's binding to calcium and integration into the hydroxyapatite matrix of teeth and bone. And although they are irreversible for teeth, the bone growth effects may be reversible when the drug is discontinued. Such dental and skeletal effects are a primary reason textbooks caution against tetracycline use in these populations, alongside other class-wide adverse effects like photosensitivity and hepatotoxicity. However, more recent clinical evidence and guideline updates have nuanced this traditional stance, especially regarding doxycycline, a second-generation, broad-spectrum tetracycline derivative with lower calcium binding affinity. Systematic reviews and pediatric data suggest that short courses, generally less than or equal to 21 days, of doxycycline are associated with a lower incidence of clinically apparent dental staining or enamel defects in children under 8 years than older tetracyclines, and expert guidelines now consider such short-term use acceptable when clinically necessary. In the context of bioterrorism and suspected aerosolized Bacillus anthracis exposure, the U.S. Centers for Disease Control and Prevention, CDC, has recommended doxycycline, or ciprofloxacin, for post-exposure prophylaxis even in infants and young children because the risk of fatal anthrax infection outweighs the potential for dental or bone effects. And evidence indicates that doxycycline's risk of staining at prophylactic durations is low. In pediatric patients, underlying diseases can profoundly alter drug pharmacokinetics and pharmacodynamics, requiring careful therapy adjustment to avoid toxicity and ensure efficacy. Hepatic disease affects drug metabolism because the liver is the principal site for the biotransformation of many medications. Impaired hepatic blood flow, reduced enzyme activity, altered protein binding, and changes in hepatic transport mechanisms can prolong drug half-lives and increase unbound drug fractions, particularly for drugs with high first-pass metabolism, necessitating vigilant monitoring and, often, dose reduction for hepatically cleared agents. Renal disease similarly impacts pediatric pharmacotherapy as reduced glomerular filtration and tubular function decrease the elimination of renally excreted drugs and metabolites, increasing systemic exposure and the risk of adverse effects. Pediatric dosing recommendations for many drugs in renal impairment are frequently extrapolated from adult data due to limited pediatric-specific studies and therapeutic drug monitoring, TDM, or estimation of glomerular filtration rate, e.g., with the Schwartz formula, is essential for dose individualization. In children with cystic fibrosis, CF, multi-organ involvement, including pancreatic insufficiency, altered body composition, changes in protein binding, and chronic inflammation, produces significant pharmacokinetic variability, particularly for antibiotics, and may require higher or more frequent dosing to achieve therapeutic concentrations. Population pharmacokinetic models support the need for individualized dosing and TDM for agents such as vancomycin and other key anti-infectives in CF. Gastrointestinal diseases, such as malabsorption syndromes and inflammatory bowel disease, reduce oral drug bioavailability by altering pH, intestinal transit, and mucosal integrity, which can compromise absorption of orally administered medications and necessitate alternative formulations or dosing strategies. Hypoxemia, often seen in chronic pulmonary or cardiac conditions, can alter tissue perfusion and drug distribution, potentially affecting the onset and intensity of drug action, while other systemic diseases, e.g., congenital heart disease, metabolic disorders, impose additional alterations in drug handling that require individualized dosing, frequent monitoring, and interdisciplinary management to optimize therapeutic outcomes in pediatric pharmacotherapy. Pain management. Pain management is a critical component of pediatric care, and modern standards recognize effective pain control as essential, with pain assessment considered the fifth vital sign in clinical practice. Ensuring appropriate analgesia is not only a matter of comfort, but also of preventing adverse physiological and psychological consequences, including stress-related endocrine changes, impaired immune function, and long-term alterations in pain sensitivity. The basic mechanisms of pain perception in infants and children are similar to those in adults, but there are important developmental differences that influence both assessment and therapy. In neonates, pain impulses are transmitted primarily along slow-conducting, unmyelinated C fibers rather than the faster, myelinated A delta fibers found in older children and adults. Additionally, the spinal cord of neonates has less precise signal transmission, and descending inhibitory neurotransmitter pathways are immature or absent, resulting in a heightened sensitivity to painful stimuli. Consequently, neonates and young infants may experience pain more intensely and respond more profoundly to noxious stimuli. These developmental considerations necessitate careful selection of analgesic agents, appropriate dosing adjustments, and the use of validated, age-appropriate pain assessment tools, such as the Neonatal Infant Pain Scale, NIPS, or FLAC scale, to ensure both safety and efficacy in pediatric pharmacotherapy. Evidence-based guidelines from pediatric pharmacotherapy texts emphasize multimodal pain management, combining pharmacologic and non-pharmacologic strategies to minimize opioid exposure while effectively controlling pain. Fluoroquinolones in pediatric patients younger than 1 year. Fluoroquinolones, e.g., ciprofloxacin, levofloxacin, are generally not routinely recommended for use in infants under 1 year of age due to concerns about potential cartilage toxicity observed in juvenile animal studies, which manifested as arthropathy and altered weight-bearing joint development. Clinical data in humans are limited but suggest that short-term use may be relatively safe in life-threatening or serious infections when alternative antibiotics are unavailable. The FDA labeling for ciprofloxacin notes that its use in neonates and young infants should be reserved for situations where no safer alternatives exist, such as complicated urinary tract infections, multi-drug-resistant infections, or prophylaxis for post-exposure anthrax. Careful monitoring of musculoskeletal symptoms is recommended, and treatment duration should be minimized. Nelson Textbook of Pediatrics, 22nd edition.